Very long day, and to all of those joining us online. I'm Bruce Aylward. For those of us joining online, the Assistant Director General at WHO, responsible for universal health coverage across the life course, and I'm honored to be hosting for the third time today, introducing a universal health coverage event. For those of you out there in PAHO joining us just now, this is our third event today. We started in the dark early today, celebrating UHC Day with our colleagues in Southeast Asia and the Western Pacific, where we had some fantastic interventions talking about the theme of this UHC Day, which of course is health. It's on the government. UHC Day, of course, is an opportunity for all of us to reflect again on the importance of universal health coverage, to recommit to some of the things that we need to do going forward to achieve this goal, and most importantly, often to launch new initiatives, new commitments, as we will be doing today, because I think Ernesto, sitting next to me, you're going to release the new PAHO report on universal health and let us know where we are in the region and where we're headed. Great, we look forward to that. And we're delighted that we also have with us, we're absolutely honored to have His Excellency Minister Jerome Walcott of Barbados. Thank you so much for joining. And Minister Santiago Garcia, Vice Minister, pardon me, of Paraguay. Welcome. And as well, we have, of course, our WHO representative from Argentina, Eva, who will be wrapping up. But with that, I want to say once again, happy UHC Day to everybody, especially our colleagues out there now in the PAHO region. And I'm going to hand over to Calypso, our Director of Health Financing and Economics in Geneva, to moderate our last session of UHC Day.
Thank you. Thanks, Bruce. So it says here good morning, so it's clearly not the morning anymore, but hello and welcome. So before we start, just to repeat the Zoom rules and let the Zoom audience know that we'll have simultaneous interpretation in English and Spanish. And to choose the language, you press the globe-shaped button at the bottom of the Zoom screen. So let me start by introducing Dr. Barbosa, the director of PAHO, who has sent us a video message, which we're about to hear.
Buenas tardes a todas y todos. Es un honor para mí acompañar la distancia.
Good afternoon, everyone. To me, it is an honor to accompany this day of universal health care, which is a universal and a human right. The theme of this year, the financial protection, highlights that people should have quality healthcare services without suffering economical problems. Today we will present a report with the title Progress Towards Universal Healthcare in the Americas. We want universal healthcare and financial protection. This report reflects our commitment to universal healthcare in a region that has achieved a lot, but he still has many challenges. We have big differences in inequalities in our regions that affect especially those populations that are most vulnerable. As that report shows, in order to have more equality, we need to guarantee the universal healthcare and to reinforce the resilience of our healthcare systems, and mainly to listen to the communities and their needs. In the Americas, the unmet needs of healthcare affect disproportionately more to the low-income populations, and that access barrier has consequences for health and for human development. For the countries with more development, normally the needs are less pronounced, whereas with middle and lower income countries, the needs can be over 30% and the mortality rates are much higher. And I'll continue in English.
Universal Health Day reminds us of the importance of eliminating both financial and non-financial barriers so that no one is excluded from health services. In the Americas, Many people face high treatment costs and have inadequate insurance, while other factors like transportation issues, long wait times, and negative experiences with providers also limit access, even in countries with high levels of coverage. I want to highlight the fundamental role of the universal healthcare partnership in the Americas. Through this collaboration, we have supported our member states in their efforts to build resilient health systems that prioritize equity, solidarity, and the right to health. I'm deeply grateful to our donor partners in this partnership, whose commitment has been essential to advancing this mission. Their support has enabled us to implement interventions that address local needs and strengthen health systems. I believe you will all find in this report new insights and reflections on the present and future paths to accelerate the transformation of our health systems. The data and the perspectives provided in the report reinforce the evidence for our call to action. We must invest in health systems that serve all people and protect the populations in situations of vulnerability from health expenses that can drive them into poverty. Finally, I extend my gratitude to our member states and partners for their dedication to advancing equitable and resilient health systems based on primary health care. This commitment is fundamental to making the vision of universal health in the Americas a reality. I leave you with one final message. Let us continue joining forces to build equitable, strong, and resilient health systems. Systems and societies where everyone can access quality services without facing financial hardship. Once again, thank you very much.
Fantastic. Thank you. Thank you, Director Barbosa. And now we will move on to the presentation of the report by Dr. Ernesto Bascolo, Unit Chief, Primary Healthcare and Integrated Service Delivery in PAHO. And we're missing, you can move the slides? No? So we're missing the thing that you pressed to move the slides. Found.
Thank you very much. It's a pleasure to present the recently published document, Progress in Universal Health in the Americas. The title is Addressing Unmet Healthcare Needs, Gaps in Coverage and Lack of Financial Protection Through Primary Health Care. This publication utilizes the most recent data to provide a detailed analysis of the current state of universal health in the regions, focusing three key indicators. The first one is unmet healthcare needs, coverage health services, and financial protections. This report identified not just current challenges faced by the region, but key policy implication and recommendation for future action on the path to achieving universal health. We can identify the main messages of this report with 6 very important points. The first one is unmet healthcare needs. 1/3 of people reporting foregoing care due to barriers to accessing care driven by both financial and non-financial barriers. We have stagnation in service coverage. After initial gains, the Universal Health Coverage Service Coverage Index has stagnated with a decline in 2021, driven by setbacks in infection disease coverage. We have financial challenges too. Up to 7.8% of the population face catastrophic health expenses, and 40.2% foregone care due to the cost. 4, we have non-financial barriers too. Organizational, availability, acceptability, and geographic challenges collectively account for over 40% of unmet healthcare needs. We have an integrated analysis in this report. The 3 indicators: unmet healthcare needs, service coverage, and financial protection, all of these indicators provide a comprehensive view of the care-seeking pathway from initial need to service utilization and financial protection. And finally, urgent action is needed. We need to strengthen data availability and monitoring for all the 3 indicators, including for unmet healthcare needs, and adopt comprehensive, tailored approaches grounded in primary health care to address both financial and non-financial barriers. I will address the key challenges regarding the 3 indicators, including our regional report, access, coverage, and financial protection. And as I mentioned before, one of the main concerns in the current situation in our region is access to health services. As shown in this map, across 17 countries, the percentage of the population reporting unmet healthcare needs shows wide variation from 3 to 73%. On average, in our region, 35% of the population faces unmet healthcare needs, a figure that has remained relatively stable for the last 2 decades. This is important because inequity is among countries. There's a clear inverse relationship between national income levels and unmet healthcare needs. High-income countries report 23% of their population experiencing unmet needs, compared to 35% in upper middle income countries and 49% in lower middle income countries. And this inequity is also present within countries. The lowest income quintile reports on average of 38.5% with unmet needs, significantly higher than the 32 observed in the highest income quintile. However, the degree of this gap varies by country depending on health systems architecture. These data highlight the needs for targeted strategy to reduce these inequities and improve healthcare access across all population groups. When analyzing what is causing this inequality in access, we find that organizational barriers are the most common cause of unmet healthcare needs, affecting on average 21% of the population, followed by financial barriers at 14%. However, the nature of these challenges, again, varies by country. For instance, organizational barriers are predominant in nations like Canada and Costa Rica, while financial barriers are more pressing in countries such as Honduras and the United States. But we need to know that the COVID-19 pandemic exacerbated unmet healthcare needs across all income levels in every country. However, the poorest population were disproportionately affected, with the highest rates of foregone care reported in countries like Colombia, El Salvador, Paraguay, and Peru. We have experienced recently a deceleration and stagnation in the progress of the Universal Health Coverage Index. The index used to track the SDG 3.8.1 has shown significant improvement over the past 2 decades, rising from 2000 to 2019 and then falling in 2021. In general, the current situation shows that while 20% of countries achieve 80 points of higher, 71 fell within 79 range, and 3 countries lagged behind at 59 points. Despite increasing in public spending on health in the last 2 decades, many countries today in the region rely on direct out-of-pocket spending to finance health systems. The impact of that varies among countries. For instance, Grenada, Guatemala, Honduras report figures exceeding 50% of the current health expenditure, while, for example, Colombia, Jamaica, and the United States have reduced this figure to below 14%. Additionally, in 2019, catastrophic health expenses impact 1.5% to 7.8% of the population in the regions, affecting 15 to 79 million people, depending on the income threshold used. In 2020, 4.4% of Mexico population faced such expenses, while in 2021, figure varied from, for example, 5.7 in Bolivia, 12 in Peru, 4.6 in the United States. This number highlights the uneven financial border of healthcare across the regions. In summary, the region of the Americas made important progress on the path to universal health. However, there's urgent need for tailored territorial primary healthcare strategies to address challenges in our healthcare system due to the variability of unmet healthcare needs and uneven financial border across the regions. These include addressing unmet healthcare needs, coverage, the coverage gaps, and out-of-pocket spending through comprehensive primary health care strategy to improve universal health outcomes. To close these gaps and increase coverage, we need to improve not just financial protection, but also reducing financial and non-financial barriers, such as long waiting time, limited provider availability, with a comprehensive and strengthened primary healthcare strategy. Thank you.
Thank you. Thank you, Dr. Ernst. That's fantastic, great presentation. Congratulations to PAHO for the report. I think it's great, especially measuring the unmet need indicator. I think that's critically important and shows all the inequalities within and across countries. Fantastic, well done, though it is quite a grim picture. So now we're moving to I have short comments by the ministers on the panel. We'll start, first of all, with Minister Walcott, Minister of Health of Barbados. So, Minister Walcott, my question to you is, how has Barbados progressed towards universal health coverage and financial protection for the population of Barbados?
Thank you and good afternoon. I must say at the outset that the government of Barbados is committed to universal health access and coverage, because we see it not only as a health matter, but we see it as a developmental and absolutely necessary as it relates to our economic development, recognizing, of course, what can occur in terms economically when the population is ill and not having access to the best of health care. We also recognize that for sustainability and cost effectiveness, that primary health care is absolutely necessary and is a cornerstone of the implementation of universal health coverage. I've just watched the presentation, and some parts of it I'm a bit bothered by, but not surprised. What I can say is that over the years, Barbados has benefited from a public-funded health system, and this has served us well. I know this evening we're also going to deal with finance, and I will come to that later. But as it relates to the publicly funded health system, which has certainly served us very well, we can boast of having free health care delivery at point of care. We have a national drug service that provides medication, essential drugs, to persons free of cost. All medication on the formulary is available free to those under 16 and over 65, but for those who are affected by diseases like hypertension, diabetes, the NCDs, glaucoma, asthma, all medication is free for them if they want it. Of course, there's a persons have the choice, and if you want to pay for your medical care, you're certainly allowed to. But this system has allowed us to achieve a life expectancies of about 78 years. Normally, we have some good survival rates as it relates to women and children. We have, certainly I see there that we have coverage of over 70% thus far in health coverage. But we also can boast that we provide care. Persons need to be sent overseas for any care that is not available in Barbados. This is covered by the government. Having said this, there are challenges. Like every other country, we have challenges. We have the scourge of the NCDs. We have an aging population. 11% of our population is over age of 65. More recently, and it's been revealed since COVID, we see the issues with mental health disease in our country. We also have the issues of financing. We have issues related to climate change. But we are trying to address these issues as we maintain that we must have universal health coverage. As it relates to the NCDs, we've established an NCD commission. We have recently taken to Cabinet a new strategic plan for the control and reduction in NCDs. We've done a number of things. We are looking at reducing the levels of exposure to certain substances. The government has shown its willingness by introducing measures such as sugar-sweetened beverage taxes, tobacco taxes to control tobacco use, taxes to control alcohol. We're about to embark on the elimination of trans fats by the end of next year. So there are these measures. The Commission also looks to help people to reduce the risk factors. We have introduced school children, a national nutrition policy, recognizing that a third of our teenage population have been shown to obese. So we're looking at these things. In addition, there are a number of, we're utilizing a number of entities to help in this entire process. As it relates to the aging population, we have faced, I don't know if it is unique to Barbados, although I heard a presenter earlier today making reference to the issues that the country is facing as regards the elderly population. In Barbados, we have the situation where elderly people are brought to hospital or brought to clinics with medical issues. Sometimes this could be just dehydration. They need to be rehydrated to be taken home. But then you hear that their relatives can no longer care for them. And in this regard, not only are we accommodating them in the geriatric system, but government has embarked on a program called the Alternative Care of the Elderly program, where we pay for them to be housed in private sector entities, not necessarily hospitals. I mentioned mental health, which has raised its ugly head. I believe it was simmering, but COVID brought it to the head. And we're looking at the whole comprehensive change as it relates to mental health policy and moving from the traditional hospitalization of these people, but getting them into the communities. And I spoke of this yesterday in terms of community care at the clinics, where nurses, etc., are being trained to provide this care in these institutions. There's a matter of the polyclinics, and we have said climate change in having them developing resilience, and there's a project to be launched shortly over the next 3 years to refurbish, modernize, and make our health centers more hurricane resilient, and indeed while greening them. And then there's the matter, of course, of finances. PAHO has provided services, PAHO WHO, where we had a number of consultants came to the island and have developed a plan for us how we can deal with the financing of healthcare in our country, recognizing that what we are doing, healthcare costs keep rising, and there needs to be some measure of controlling this. And this is something that will engage our attention going forward. The government has the report, and we're supposed to have discussions with the consultants shortly. I just want to mention one thing, that having said this, I've seen a slide that speaks to high out-of-pocket costs for healthcare in Barbados, and it's almost enigmatic, because in a situation where all care is available free, where essential drugs are free, that you could be seeing such a high percentage of the healthcare expenditure coming from out-of-pocket expenditure. Yet when I dig further, I see that 1 in 3 people who are employed have health insurance, yet the cost from health insurance is less than 6%. So it's a little baffling to me, but I'm not a health economist, neither I'm a statistician. But I just find it a little concerning. So much, however, I would say is that culturally, there are Barbadians who always feel like they must pay for their health care. I had a grandmother who insisted that even though she could go to the clinic, she wanted to go and see her doctor, and she would pay him. And thank you.
Thank you, Minister Walcott. And now we're moving to Minister Garcia to tell us about the experience of Paraguay progressing towards universal health.
Well, muy buenas tardes a todos.
Good afternoon, everyone.
Quiero presentar la
I would like to present
del Ministerio de Salud Pública
the experience of Paraguay. We are presenting the results from our health and well-being ministry. You have the title in both in Spanish and Guarani. We are presenting our comprehensive health service networks. You have the country here. You have in the center of South America on the right, you have Paraguay with its 17 departments. It's a unitary republic with governors. We have 6.5 million people in approximately 6 million square meters. We have some integrated networks focused especially in primary healthcare. We try to promote good practices and quality of care of people so they can access drugs and healthcare and services. Paraguay is therefore building in its new government, and the new president of the Republic is committed to the healthcare system. His commitment is such that after 34 years, we have started building 6 large hospitals, which will start being built in 2025. In 10 days, we will inaugurate our first digital hospital, fully digital hospital with 200 beds, and we have cooperated with the Republic of Taiwan, so all the information of patients is digitalized. From now on, all the units and hospitals that will be inaugurated will be fully digitalized. About digitalization, when this new government started, there were 237 hospitals with digital services. Now we have 700. So the growth is around 300%. So most of the progress that we have had in public services for health are universal health system, access to health care, mental health, disease prevention and control, sexual and reproductive health, and health emergencies response. On the first item, universal health system, we have new family health units, and we have the primary health care, which is the gateway to healthcare services in Paraguay. We have 937 health units, and they covered 100%. To cover 100%, we would need 1,700. We will have 97 new units this month. And during this mandate, this new government mandate, we want to start between 300 and 400 new units to cover the whole territory of Paraguay. The reorganization of the integrated health service, which was very fragmented, we have tried to simplify it, and we divided it in levels with specialized attention and general hospitals and specialized hospitals. So we have different levels of complexity. On the item of access to health, in this point, we have taken into account geographic barriers, and we have tried to work quite a lot on this, because sometimes there's a barrier to access due to the opening hours. So we try to extend the opening hours, the family units, from 15 to 20 hours. And in some hospitals of the capital of the central department, which is 40% of the population is located. We started surgical marathons. We did 300 surgeries in 15 months, and our social services are also working on it. And in the night shift, we had 1,500 patients in 15 months. Here we have the different types of hospitals. We have general hospitals and specialized hospitals, and APS covers all of them, the social security. And our social and healthcare service is fragmented. So the Republic attends 70% of the population. The social insurance attends to 20% of the population, and the rest is divided between different healthcare providers, including military health provider. In mental health, we saw a huge change. We had a hospital that was older than 130 years, and it's shocking to hear, but many people just went to give their family members to deposit them in this mental hospital. In 2022, we passed a Mental Health Act, and today we have had a jump start in the protection of mental health. We managed to close that long stay mental health hospital, psychiatric hospital, and we put these 64 patients that remain there in care homes where they have a dignified care. And we still have 70 people in that hospital, and we're working to move them to more adequate places, so that the idea is that we can stop having patients for long-term care. We have short-term care in the hospital, so anyone who has any short-term mental health issues, so they can stabilize themselves and they can go back to their families after that. On the decentralization of mental health, we're working with the doctors of the mental health unit so that they can see if there's any problem in the whole of territory, so that they can refer them to specialized centers. On prevention and control, disease prevention and control, we are working with oncological patients. This is a very important patient group that have been attended by other sectors, and we don't know how many cancer patients we have in the country. So we're trying to correct this so that we know exactly how many oncological patients we have, so we can help them to give them care. We also have a registration of type 1 and type 2 diabetic patients, so we can give them their medication, and same thing for high blood pressure patients. And we guarantee medication on all levels of care, from the least expensive to the most expensive medicines, which is the oncological medicaments. On sexual and reproductive health, we're working on this decreasing maternal, fetal, and neonatal deaths with training, case analysis, and with timely access to services. On the health emergency response, the policies have included crisis management and investment in health infrastructure, new hospitals away from the capital, and there's more in the pipeline. The idea is to avoid a long journey from patients to submit themselves to treatment. So we want to treat them closer to their homes. Our gold standard is teamwork, good work, successful work. Thank you very much. Abuye in Guarani.
Wonderful, fantastic, thank you. And now to close, we will turn to Dr. Lopez, the PAHO WHO representative in Argentina.
Thank you very much. Good afternoon, good morning for those of you in the region. It is a real pleasure for me today to close this session of the launch of the report, a report that provides us with a very strong overview of the situation in the region, but it also gives us a deep reflection as to the road ahead. So first, we have seen that significant gaps prevail. So unmet healthcare needs, there's barriers that go beyond financial, so geographical, organizational specifically, and the gaps affect disproportionately low and middle income countries, vulnerable populations, and they're closely correlated with avoidable mortality. And interestingly, despite the advances that we've seen in closing the gaps in health coverage, there's a couple of reflections that might be food for thought. One is the increase of coverage in essential services has not gone hand in hand necessarily with the reduction in unmet health needs. And we've seen a stagnation. So this is food for thought as we move forward, working and trying to achieve universal health. What does that mean? And we've seen that we continue to have lack of financial protection, and there's way too many still in the region with catastrophic health expenses. But what's very interesting is the report also provides us with a way forward, like a roadmap as to where do we want to go. This is something that we've been discussing also over the last couple of days. And one of the key issues, as discussed also by the two ministers that are here today, is primary health care. So this is, we know, the foundation to build an equitable and a resilient health system. But to achieve this clearly, and we've seen this by the ministers, we need targeted, comprehensive approaches, interventions, and addressing the challenges that primary healthcare services have in different countries. So this targeted approach in country level is very important. And when we continue thinking about this, we see that we need more integration. We've been discussing about it, integration in terms of programs, communicable, non-communicable diseases across the lifespan. How do we ensure that we increase efficiencies in how we work in primary care, to make sure that we reduce the burden on the system, to make sure that we are more efficient for patients and for families and for teams in those areas, in those sessions, and making sure that we apply the territorial approaches to the primary healthcare setting. There is a final area that I'd like to make us think about as we move forward in this issue. And it has to do with commitment, and it has to do with how we leverage today's context. It's clear that we need to redouble how we work together, how we work between international organizations and governments and civil society. How do we bring along other actors that are not so present in our partnerships today, like the private sector, like the young people? And this is very important because each of these actors hold a key to addressing some of these challenges that we have not been able to tap on yet. So as we work together in identifying how do we set out to the next steps, we need to ensure that we have comprehensive strategies from each of the actors that in the end would be more than the sum of the parts that we would have done independently. Member states, and we've heard about that from our ministers here, need this political leadership. We've seen some countries that really are at the forefront of this. And we need to think, how do we help to identify the incentives that can align the changes in those policies that are beyond health, but that need to be changed to address the universal health coverage agenda. And particularly in the countries where we have the centralized health systems or where we have federal governments, we need to think about how do we leverage these opportunities? How do we work together and embed some of these ideas, some of these new ways of doing things in the different jurisdictions in our overall approaches to addressing the remaining challenges that we still have ahead? Final thought is for us at PAHO and at WHO. What does this mean for us? I mean, we've been pivotal in advancing the agenda, but we have those still challenges prevailing. So as we set out to the next steps, how do we do this differently? How do we work better together? What is needed? And one of the things that maybe we need to think about is how do we come out of our comfort zone to explore ways to expand our technical cooperation, to ensure that we foster innovation. We talk about telemedicine, but what does it mean to scale this up? We talk about artificial intelligence, but what does it actually mean in our day-to-day? How do we use it, really applying it to primary healthcare? But we need to go beyond that, analytics of big data, identifying ways to more efficient resource allocation, thinking about these differences also across territories, across needs, across populations, etc. And how we work across sectors. We keep talking about it. We need to work together, we need to do it better, but we haven't cracked this yet. Private sector, the youth. And as we move forward, how do we actually break the silos? In primary care, we all know that we have this vertical approach. At country level, we work with it every day. But it's not only at government level, it's at WHO and PAHO as well. So how do we do it? To make sure that we ourselves start by identifying how do we crack this? How do we implement these more horizontal approaches that then we will be able to see through all of these other recommendations in the next reports that we will be doing. So the final word is that we applaud the report, the insights, the roadmap. I think we identify where the challenges are. And beyond all of these, universal health and achieving UHC will not be possible if it wasn't for all of you, from all of us working on these areas. It's such a privilege to be part of this. And I want to finish by just saying a happy Universal Healthcare Day.
Fantastic. Good. Excellent. Well, thank you. Thank you all. Thank you to those who joined via Zoom and to you who stayed on and to the panelists, and have a lovely evening.